today. So welcome and thank you for joining our Spotlight event, where we're going to be talking for the next hour around some exciting work we've been doing around virtual wards, particularly around patients and clinicians' views around virtual wards and their perceptions. I've got some really great colleagues that have joined me today, who I'd like to bring in to introduce themselves. So Charlotte, would you like to introduce yourself?
Yeah, of course. Hi, everyone. My name's Charlotte Lynch, and I'm Strategy and Policy Lead in the National Virtual Wards team. Really excited to be here today.
Thank you. And Bex?
Afternoon, everyone. My name's Bex Winterbourne. I'm a vascular surgeon by trade, but I'm Clinical Director of Bristol, North Somerset and South Gloucestershire NHS at Home programme. Really passionate about how we deliver more acute care for our communities at home. So thanks for having me today.
Great, thank you for being part of it. And Kate?
Hi everybody, I'm Kate Knight. I'm a Programme Director at SCW with a background in social marketing and behaviour change. So this has been a great piece of work. I'm looking forward to talking about it.
Great, thank you everybody. And before we kick off, obviously just a few housekeepings. I've said already that the session will be recorded, but if we could ask for you to turn your mics and cameras off just while unless you're the panel, unless you're, so we can see the slides, but there will be plenty of time after the sessions for questions. So start thinking of your questions now. So yeah, there'll be plenty of time for Q&A then, and we'll take the slides down and we'll be able to have that conversation. So the panel today we've already introduced, but what we're going to hopefully cover in the next hour is sort of a national overview from Charlotte around virtual wards, the importance of clinical and patient engagement, our model and our approach and the insights that we've done, and then obviously the meat of the session today was really what did we hear? What are patients and clinicians actually telling us about virtual wards, and how can we sort of take the next steps in the development? So I'm now going to hand over to Charlotte.
Brilliant, thank you. Could I have the first slide, please? Great. So I've just got 5 minutes at the start of this session just to give you a bit of an overview of what virtual wards are, where we are in the programme, and also a little bit about the evidence base and what we know so far about virtual wards. So I'm sure many of you already know this, but virtual wards are about providing hospital level care in people's own home or the place that they call home. They're for people with acute care needs who would otherwise need to be admitted into hospital. The way that you go onto a virtual ward will vary. So you might be on an admission avoidance pathway. That means that you won't ever be admitted into hospital, although you might later on in your journey if required, but you might be referred onto a virtual ward, for example, by community services. You might have a paramedic who comes to your house and says, actually, we think that we can provide you care in your own home if you'd prefer. Or through 111, you might also go to ED and be put onto a virtual ward. Or you might be on an early supported discharge pathway. So that would be where you've been an inpatient in hospital, you've stabilised a little bit, but you need acute care still, and it's decided that actually you can continue receiving treatment in your own home. So you're able to leave hospital a little bit earlier than you otherwise would be able to. Virtual wards provide the same things that you would expect to see in hospital and receive in hospital. This is about equivalent level care just within people's own houses. So you'll have access to hospital level diagnostics. You might have point of care testing. We're increasingly seeing that within our virtual wards. So having tests in your own bedside in your home. You'll have access to the same hospital level interventions that you would receive if you're an inpatient. So if you required IV fluids, therapy, oxygen, those kind of things, they'd be available to you. You'll have care from a multidisciplinary team, so you'll be contacted on a daily basis. How that works will depend on your needs and your preferences. So you might have a clinician come into your home on a daily basis to check up on you and see how you're doing. You might have a video call with a clinician or a telephone appointment, depending on what works for you. You'll have access to the same speciality advice from expert clinicians as you would if you were in hospital. And the other thing just to flag is that virtual wards are meant to be a short-term intervention, just as the same as you were if you're admitted to hospital. It's not meant to be a long-term thing, and most people stay on them between 1 to 14 days. Could I have the next slide, please? So in terms of where we are nationally, virtual wards are really being delivered at scale now, and the number of virtual beds that are available across the country are increasing all the time. And we've hit some quite big milestones recently. So we now have over 10,000 virtual beds in place across the country. Over 240,000 people have been treated on a virtual ward since April 2022. And in the last month alone, over 7,000 people were being treated on a virtual ward. And it's great to see that this is becoming more and more the norm for people and an option that's available to them. And we want to build on this great work that's already taken place, so making sure that all patients across the country have access to this care, particularly with a focus on acute respiratory infection, frailty and heart failure, which are our 3 priority pathways at the moment. Can I have the final slide, please? Thank you. The evidence base for virtual wards is growing all the time, but we're not there yet. We don't have all the answers, which is so great that this report's being launched today, because I think there's some really rich and interesting insights in it that's going to really help to build the picture further. But the evidence that is available so far paints quite a positive picture. So we're hearing from the evidence that's available that patients have comparable, if not better, outcomes to people than if they were inpatients. So that includes things like hospital readmission rates, mortality. We're also seeing that people who are on a virtual ward are less likely to require being admitted to a care home after being on hospital, because they're less at risk of things such as deconditioning, delirium, infections. So there's really positive patient outcomes. We're also hearing from patients and carers that they really like this type of care. Really simple things like just being able to have home comforts, being able to be in your own bed, eat your own food, be around your loved ones, be around your pets even, makes a huge difference to people's experience, and they feel like they're able to have more personalised care than they might otherwise be able to. We're also hearing quite positive insights from staff as well, who are really valuing working in this way. So being able to really get to understand what their patient needs. I think going into a patient home gives you a whole new perspective on what that patient might need, gives you insights into their life that you might not otherwise be able to have. And there's also opportunities to work in quite flexible ways as well. And finally, in terms of the evidence base, we're also starting to see quite exciting and promising insights about what virtual wards can do for the system as well. So helping to keep people out of hospital when they can be treated in their own home really helps to free up that capacity for people who might need to be in hospital more than others, and can really make a difference as we move into winter as well. As I said, we're continuing to evaluate and learn all the time. This is still a relatively new programme in the grand scheme of things and in the history of the NHS. So we're working with lots of different partners such as NICE and the Health Foundation to really get to the crux of what impact virtual wards can have, which is why I'm so pleased as well to be here today, and just to be having read through the report is a really useful piece of work. So excited to hand over now and to hear more about that work too.
Great, thank you so much, Charlotte. That gives a really good context and start to our session. So thank you very much. I'm now going to hand over to Bex, who is going to talk to us about some of the sort of clinical and patient engagement importance of virtual wards. If that's okay for you, Bex?
No problem at all. Thank you. Thanks, Charlotte, for your national overview. So, I think the reality is that we're at a time where we have an aging population. We have more and more people unfortunately becoming acutely unwell, requiring hospital level care, and the infrastructure that we have in place, we've seen over the last at least 5 years more and more strain and stress on the system that we currently have. And I think that developing at-home pathways, virtual wards, is a real opportunity to join up care and provide sort of that holistic, personalised approach. I know, where I would prefer to be if I was acutely unwell. And when you hear just the anecdotes and stories from staff that work in this space around being invited, you have to remember that people are inviting strangers into their homes to receive this acute level care, and yet the rapport that build up between those patients, their families, and the staff that go in is quite incredible, and I think gives a really different experience for all. For the patient and carer, they have the familiarity of their own surroundings, always describe that, having your own mug, you know, the mug or cup that you like to have your cup of tea out of, having your pet beside you, having your family around you, the ability to move in a space that you're aware of, so less risk of falls, ability to you know, get to your own bathroom. We know the impact of, you know, being in a hospital ward, not having your own bathroom space, curtains that supposedly create privacy, whereas actually what we're delivering here is an opportunity for that same level of care in people's homes. And from a staff perspective, I think the opportunities around interaction are really, really powerful to provide that post-personalised approach. And it's also how that joins up with the wider perspective. So particularly when we're talking about treating patients with respiratory disease, heart failure, it's about their ongoing journey. That's why I have a bit of a dislike of the term virtual ward, because I think this is a pathway of care, and what we don't want is to be considering this in isolation from the other levels of care that we need. And we really want to be thinking about a personalised care approach and how we ensure that patients who have been through our at-home pathway feed seamlessly into chronic condition management, pulmonary rehabilitation, opportunity for health coaching, well-being coaching, how we link into other services, how we ensure that we are really providing that integrated approach. But this is all really new. And when people think about the NHS and they think about what they do when they become unwell, the default is still about ending up in hospital. And so I think that this evidence really gives us an opportunity to spread the new narrative, shift the culture on the way that we deliver healthcare for the future for our populations, and allow that communications piece to happen, both for the public, but also for staff. Because again, there are real opportunities for staff around a real varied opportunity to learn new skills, to meet new people, and a real team approach, which I think in hospitals we've lost a little bit in the way that we've shifted very much to shift working, certainly from a medical perspective. So I think that ability to be part of a team, that can't be underestimated. So I'm really looking forward to seeing some of the insights that have come out of this important piece of work, and then also looking forward to how we can learn from those and really make this impactful in the way we deliver healthcare for the future.
Great, thank you, Bex. That was really helpful and really insightful. So thank you for sharing that. Okay, so we're now going to move on to talk about the report. So I'm going to hand over to Kate, who's going to talk through the sort of our approach and methodology around
Brilliant,
the
thanks,
report.
Ruth. I'll do the slightly more boring bit about telling you what we did and how we did it, and then Ruth's going to get the glory and talk about the actual insight, which is really exciting. And this has been such a great piece of work to work on. I think Ruth and I will both say we've got so much out of it. It's really, you know, really quick. You know, I've heard Charlotte talk about how quickly virtual wards and virtual care is rolling out, and post-COVID, that's all been incredibly speedy. And SCW have been involved in so many of elements of that, working with our partners across system, whether that be helping to design clinical pathways, whether that be procurement, or actually, Bex, as you were just saying, sort of the comms and the culture, such a huge part of this piece of work, communicating with patients around virtual care and what it means is just so critical. My background is in public health, but quite specifically in social marketing and behaviour change. And everything me and the team do is really around ensuring that we have the right insights and the right knowledge in order to roll out interventions and care in a way that responds to people's needs. So how can we make sure we have the right evidence base to understand motivations and barriers in terms of accessing care? So we wanted to explore what was out there. Charlotte's already touched on the fact that there's emerging evidence in this area, but there's not a huge amount out there in terms of public and staff perception around virtual care. You know, that the term in itself, what does it mean? Virtual care, virtual wards. We hear other language such as hospital at home. They all come with quite strong connotations, really. You know, having the word virtual and healthcare next to each other can be quite frightening for people. You know, what does that actually mean in terms of the care that they're going to receive when they're feeling very ill? So we wanted to expand that evidence base. And so we decided to go ahead and carry out this piece of research, and we did it working closely with two of our systems. So firstly, we've got Bex here from BNSSG, and we also worked closely with Hampshire Acute Trust. So we brought in partners from an acute perspective and a community perspective to give us access to patients and clinicians across those areas. What sort of language should we be using when we talk to people about virtual wards? What about our staff who are actually working in them? Unless they're fully aware of what people feel about virtual wards, how do they know they're using the right language to promote them and to talk about them? And I think often we don't get that right across the system. Should we move on to the next slide? So this is just in terms of what we did, and Ruth will talk about the outcomes a bit, but we carried out some really in-depth qualitative interviews with 3 groups of people. So firstly, you can see here audience 1, which was people directly working within virtual wards. So whether they were administering them or leading them, we spoke to a number of people in that area, and I'll show you a bit more about who they were in a second. Secondly, audience 2 was patients. So, and we talked to patients working across, patients in having care across 3 areas: frailty, OPAT, which is people receiving sort of intravenous medication once they're discharged from hospital, and respiratory. Bex has mentioned respiratory already. So we spoke to patients across those 3 areas. And then thirdly, indirect staff. So again, really important, the clinicians who are referring people into virtual wards. What are their perceptions of what's going on? And then we also carried out a piece of quantitative research. So we wanted to reach significant numbers of people. So we had some robust data, and we ran a quantitative survey with 2,000 adults nationally, a national survey. And let's just move on to the final slide. And this gives us a little bit more breakdown of who we spoke to. So in total on the left here, we had 43 in-depth conversations with staff and patients. And you can see here across BNSSG, HHFT, and a couple in Somerset as well. And then on the right here, our quantitative survey, and this is quite a significant numbers, 2,000 people to speak to. Those are large numbers of people nationally. And we ensured that as part of that cohort, we were speaking to people who had caring experience. We wanted to hear from carers, although I still think there's a lot more to be done in that world. It feels to me like that's the sort of next stage of this sort of work. People who'd had experience of both virtual care and in patient care, so there could be some comparative data. And I suppose the last thing to say is that when we were developing this report, we wanted there to be some actionable insight, if you like. So as well as giving you an overview of perceptions, what can people in systems do to actually help with the rollout of virtual care in your systems and make it effective? Okay, I'm going to hand over to Ruth now to take us through the findings.
Thank you, Kate. I was just going to pause there if anyone had any sort of burning questions around any of the presenters so far. There will be time at the end for Q&A as well, but I just wondered if anyone had any burning questions now. If not, then happily move on. No? Okay, no, that's good. Okay, so as Kate said, I get all the glory with sharing our report with you. As I said, Kate and others have said, it's a really exciting piece of work because we think sometimes we know, but actually reading some of the insights that we gained was really interesting and not what I thought would be coming out of it. So yeah, so some really interesting insights. So sort of a general summary, and we'll go into some more detailed slides in a minute. But general summary was that awareness among the general public was very limited for virtual wards, whatever name we called it. That interestingly, generally from the public, if they viewed that virtual wards was not comparable in care to an inpatient stay. There was still some sort of hesitance around being cared for at home and what that meant versus being in hospital. Increase in referrals definitely was being seen, but clinicians did say that more information needed to be out there and much more widespread. Unsurprisingly, as we've all touched on already, terminology was confusing for patients and carers, and also the technology, pluses and minuses for the technology involved. Also, they're generally viewed very positively with multiple benefits for patients and carers, which is good. And also the referral process, which we'll go into in a few more minutes, was rarely seen as a barrier for people, which was good. So referrals seemed to be quite smooth. There was a concern generally around from healthcare professionals that there was an increase in unsuitable referrals. So I think that's an area we should dive a little bit deeper into why that might be, and obviously still lots of work to be done around communications for virtual wards. So to make it a bit more pretty, got some nice pictures and diagrams. So this has come directly from our report, as will the following slides. We've still got quite a few to get through, so I will go through them at pace, but plenty of time for questions at the end. And also the slide deck will be shared with you. So if you've got any questions post-event, then you can have an opportunity to view them as well. So as we said earlier, amongst the public, generally awareness was limited. As you can see here, 66% of the population didn't really, have a view. Had they heard about the terms of virtual wards? The big red bar, 67. Actually, no, they hadn't. Hadn't heard of virtual wards or hospital at home, but some had. But the majority hadn't. Interesting to see some of the sort of, the terms being used by the public around virtual wards. Interesting sort of one there. I'll just pick out one. Virtual wards makes me think of maybe chatting to doctors over a laptop, whereas hospital at home makes me think of having home visits by a doctor or a nurse. So just that change in terminology, how the perception really changes, from a public perspective. Virtual ward sounds like a VR setting. Hospital at home sounds disruptive and intrusive. So not always positive messages. So lots of quotes from the public there that we need to be considerate of. Patients really aware of virtual wards prior to being admitted. Obviously, once they'd been admitted, yes, they knew all about it. But prior to admittance, there was very little awareness. Quote there from one of the frailty nurses, totally new to them. Every patient I've referred didn't know about virtual wards. They'd never heard of it all. Once it explained and had their leaflets, obviously then they were aware, but prior, very little knowledge. And obviously, again, as we say, the terminology is confusing, even between virtual wards and hospital at home. What were the clinicians saying? We've heard a little bit around what patients were saying, but what the clinicians were saying, one here from BNSSG. Virtual wards relatively new. People need to be convinced of their value, and something about success stories. I think that's one of the things that we need to think about. Is there's lots of success stories around virtual wards and hospital at home, and how can we spread that message around as well. So moving on then, one of the questions that we asked in the quantitative survey was around levels of care on a virtual ward, and were, as you said, if you're on a virtual ward, will you be able to get medical assistance? The majority were saying yes. Are you on a virtual ward to get, quickly admitted to hospital? So there is lots of positives, and we tried to sort of have a look, particularly as BNSSG being in the southwest and Hampshire being in the southeast, to see if there's any differences that way, but we didn't really see much difference in the two areas. Still a long way to go around, being comparable to an inpatient stay. As we asked here, care on the virtual ward should be as good as being treated in an inpatient stay. 36% thought it wasn't. However, 30 did. So there's, obviously there's still a way to go on this, but making inroads, absolutely. And I think that comes back down to what we talked about earlier around the understanding of what a virtual ward is and isn't. Some more numbers here around discharge, and that's one of the things we'll talk about a bit more around discharge, because that was one of the areas for improvement, I think, that really came out for our patients. So current barriers. 4 key areas that came out from patients and clinicians around sort of virtual wards is it's not front of mind for people. So when they're doing a referral, an onward referral, whether it's from primary care or from the acute end of things, virtual wards still aren't front of mind, and so they're not automatically thought of as a referral point. Obviously unaware of specifics on virtual wards, and that came from both clinicians and patients. If you think about a GP, busy GP sat in their practice with a patient, they really need to be clear and understand, what a virtual ward does, so they're clear about that admission. Lack of understanding of the care being offered, and that came from patients and clinicians. So if someone's discharging somebody into a virtual ward, they need to really be clear around what is being offered, so that they're confident in that discharge. And also the final bit on this around the barriers is around concerns about clinical confidence. And we saw that from both sides, from admitting in from a community setting, are the virtual wards able to provide that increased level of care that patient needs, and also from a discharge perspective as well. Are the virtual wards able to manage this still potentially acutely unwell patient? So a little bit of work still obviously needs to happen around that understanding of clinical confidence, to ensure that the right people are getting onto the virtual wards. Couple of my favourite slides now, which really I think was really insightful around asking patients and the public around who they thought would be suitable for a virtual ward. So we think about the pathways that are being enhanced around frailty, for example. Our public are saying that they thought kind of adult age between 18 and 74 would be the most suitable. They didn't think it would be suitable for 75 plus, which I thought was interesting, as there's lots of frailty pathways out there, and also for children, particularly as you sort of go down the ages from 17 downwards, the younger children got the more inappropriate. The general public felt it would be for a child to be on a virtual ward, which I thought was really interesting insight. Also, we looked at, we asked the general public around, you know, what we thought the suitable pathways would be within a virtual ward. And if we go back to what Charlotte said right at the beginning, you know, the national pathways and a lot of the pathways that are being explored at the moment around respiratory, heart failure, frailty, you know, they're all down the bottom. They're all the ones that people said they didn't feel would be appropriate. And obviously that links back to, I think, the, you know, the not being clear about what a virtual ward is, what it can deliver. So obviously the things, you know, at the top of the chart were the things that people thought would be suitable. Very much, I think, sort of the primary care end of the world, you know, sort of skin conditions, ear disorders, COVID, which is interesting because obviously that has been used during the pandemic, injuries, eye diseases, digestive disorders. So yeah, so not the sort of acuter end of the spectrum. And as you go down, as the less more uncomfortable people would be with being treated in the community, as you see the bottom three, you know, frailty, abnormal tissue growths, circulation and heart conditions, and also respiratory. So it shows we've got a bit of a journey to go to talk to patients, I think, and the public around the benefits of treating some of these conditions within the community. But it wasn't all doom and gloom. So generally virtual wards were seen very positively by patients and by healthcare professionals. You know, some of the things that came out to us were, you know, patients felt much less anxious being on a virtual ward than being in an acute trust. Healthcare professionals felt it did relieve pressure within systems to be able to manage patient flows. Families and carers felt reassured by virtual wards, as I think it was Beck saying earlier, you know, that people are really, you know, much more comfortable being in their own environment, having their own mug, and their families can come and see them whenever rather than just having a hospital visiting time. And interestingly, healthcare professionals, which will come on to a little bit more shortly, is around the satisfaction they got around supporting patients on a virtual ward. So from a job perspective, they got real satisfaction dealing with this kind of cohort of patients, which was really, really interesting. Obviously, biggest benefit for families and carers was reassurance, that they knew there was someone at the end of the phone, or if a virtual ward was being supported by technology, then someone was having a sort of constant read of things, so that there was a lot of reassurance that there was wraparound for that patient being at home, that they weren't just sort of discharged and then just left. It was either sort of face to face or there was a virtual element, that they knew that there was somebody there, that if something were to go wrong, they would have someone to help and call on, which I thought was really a really good and positive benefit from the virtual wards. Again, as we just sort of touched on, healthcare professionals working in the virtual wards perceived a real personal benefit to themselves. They were able to dedicate more time to each patient, being able to spend that time and really understanding the patient and their circumstances, their family setup, and help them to understand their disease or their pathway progression. They said it was had better understanding of patients. So obviously when there was when they use the technology and then maybe a dashboard, they could really understand you know, the patient and their disease trajectories. They found the work was varied. they gained a greater knowledge of different conditions, and they were able to engage with a mix of clinical specialties. So if someone was on a respiratory pathway, for example, they may be able to, link with the physio, the pharmacy, the consultant. So they felt that was really beneficial to them and their working environment, which I thought was a great benefit to come out of it. So what we've tried to do in the next sort of few slides is look at the sort of emotional and physical benefits for patients when they're on a virtual ward, because they're obviously equal measure, but both equally important. So from a physical perspective, obviously they felt the importance were things like reduction in risk of infection. They were able to maintain physical activity and be much more independent, being at home, and they perceived that their recovery was quicker because of those benefits. They felt much more comfortable and less anxious as they were at home. They felt reassured and very supported by the healthcare professionals. And also they're able to learn and manage about their conditions, as were their families, be able to understand their conditions much more than just having a hospital episode of care. Some of the drawbacks, also we've put in sort of functional and emotional drawbacks. Some of the patients had difficulties with some of the technology. They didn't feel very confident using it. Some did talk about managing home visits. I think as Bex talked about, opening your home out to strangers, and that was a concern to some people, and also the number and level of visits that were coming through their front doors. And some did perceive that there was a lack of support rather than being in a hospital bed. Some were nervous about taking responsibility for their own conditions, and also, as we all remember in all of our services, it's not a one size fits all. So where some felt very reassured about being at home with their family and support network around them, if they don't have that support network around them, it could be perceived that it was much more lonely being at home rather than being on a hospital ward, maybe with other people around them. And there was a concern around time taken to respond when something escalated in their medical condition, rather than perceiving it would be much quicker than if you were in a hospital bed. Excuse me. So some of the practical negatives were a big factor, particularly for frailty patients. So as we said, the ability to use the equipment that was given to them, there was some concern around that. Managing the home visits and the lack of support around as well. And this was specific around the frailty patients, which I think goes back to where we looked at the age, the age profile and the perception there. And obviously some of the emotional negatives as well for virtual wards. It was daunting, was the word we heard sometimes. It was daunting for patients, being able to sort of, take responsibility, the medical support, maybe potential, the loneliness, the isolation. So we need to think about, when we're sort of developing these pathways, how could that be, counted? Just conscious of time, and we need to get to a few of the really good slides so we can leave some time for questions as well at the end. It's a busy slide, so you can look at it in your own time, but it was just really interesting to see, how inpatient hospital stays were largely associated with negative emotions, and we heard words like boring, lonely, stressful, worrying, frightening and confusing, whereas from a virtual ward we heard obviously mostly the reverse of those. So what we thought would be helpful was, obviously the patient feedback obviously we had was generally very positive. Obviously, yes, there is still more to do, but we kind of tried to sort of rate it to see where the hotspots might be. and sort of admissions and monitoring, generally the feedback was really good. Referrals, you know, was moderate. There was still a little more work to do, but actually we found that it was the discharge process and the discharge element of the virtual wards that needed the most development and the most work doing to it. We heard things like patients felt that they were sort of abandoned and, you know, thrown off a cliff almost, you know, once their episode of care had finished, that was kind of it. They didn't really know what was happening next. And obviously, remember, this is perception, not necessarily fact, but this is their perception of being discharged from a virtual ward. And yeah, was that they did feel that they were there was a lack of communication. So communication, as we said, was not always clear, and patients did have a sense of abandonment. Patients within this research sample, they tended to be staying for a period of 7 to 14 days, which obviously marries with what Charlotte said right at the beginning. Obviously the doctor confirms they're happy to discharge, and obviously then they, you know, sort of inform the patients. But obviously there's something there that we need to be thinking about to strengthen that as well. And obviously then we've got the monitoring and the follow-up. Interestingly, around the monitoring, we did hear really clearly from the patients we talked about from BNSSG, as they use Doppler as their equipment provider. We heard really positive noises from those people that use the Doppler box. They felt that everything was given to them. There was no perception that they needed to have anything themselves already, that everything was given to them. It was quite easy and straightforward to use. So that was really interesting to hear that came out quite strongly from the BNSSG patients. Okay, so last formal slide. So in sort of wrapping up, both healthcare professionals and patients generally in our report felt that virtual wards were really important, and they were really sort of necessary initiative going forward within the NHS. We did hear about you know, we need to think about the kind of face-to-face consultations versus the technology. We need to have, you know, the right investment going into virtual wards. We need to have the right staff going into virtual wards. But yeah, generally it was a really positive positive feedback and a really important initiative to be moving forward within the NHS, which I think is great. It shows we're all on the right track. So I'm going to stop sharing my slides so I can see people. What we'll do is, obviously the report, this is only a snapshot of our full report. We're really happy to share the full report with systems if they would like to have a full copy of the report. What we'd like to do is, if you'd like the report, then contact myself or Kate, so that we can sort of talk you through it, because it just needs a little bit of sort of context around it rather than just sort of having it blind. So if you'd like a copy of the report, please please contact us, and we'll be really happy to talk you through it and share the full report. Okay, conscious we've got sort of 10 or 15 minutes left. I'd really like to sort of open the floor to see if there's any questions that people have around either our report or virtual wards that we can hopefully field as a panel today. Any questions? Just put your hand up as normal with Teams. Great. I think it's Mandy Waldham.
Hi there. Yeah, I did put in the chat actually. I was just wondering, I just thought that was so interesting about the perception of what we think about what the pathways are, what suitable pathways are, and actually what the public think. And again, I think, is that an example of, again, the sort of clinicians saying our hospitals are sort of so full, and actually, oh, we know that older people can have the worst outcomes if they go into hospital, so let's focus on that. But actually, patients and public think actually that is the right place for them. So I thought that's really interesting. But also, I just wondered, yeah, was there a sharing of what we meant by frailty when in the survey? Is there a sort of an understanding, do you think, of the general public about what we mean by frailty?
That's a really good point. Bex, would you
I'm
be
not
able?
sure lots of healthcare professionals know.
Yeah, that's a really good point. Actually, I don't think within our survey we stipulated what we meant by frailty. So I think it was their own perceptions of what they meant. They thought frailty was.
Yeah.
But we didn't stipulate any particular, terminology or definition, should I say?
Yeah.
Ways. Could I just come in on Mandy's first point, because I think it is a really interesting point, and particularly around the older age groups. And I don't know if, Mandy, you've seen, and I can share in the chat as well, that the Health Foundation also did some qualitative research recently with the general public. And I think what's really interesting is that from their research, actually people with long-term conditions and older people were actually more likely to say they'd like to go onto a virtual ward. So I wonder if this is also an element of younger people making assumptions about what older people would benefit from, and actually older people themselves thinking, once it's explained to them in particular, this could be a really good thing for me. And I think sometimes we write off older people and say they won't be able to use the tech, it won't be suitable for them. But the reality can sometimes be quite different to that. So yeah, I wonder if there's an element of that too.
And I think, sorry, just quickly, I can see lots of hands going up, but so much of this comes back to the communications, doesn't it? And getting the communications right.
Definitely.
We're not.
Certainly the people that we're seeing on our NHS at Home service in, Wiltshire Health and Care. I mean, even yesterday, older people, they're just not, they love it, and they're just not wanting to go into hospital at all. And again, it's maybe about the people in that survey not being representative of that older population, maybe. Yeah.
Yeah, absolutely. No, that's really helpful. Thank you, Mandy. And thank you for starting off the questions. It's always difficult to put your hand up first, isn't it? So thank you for starting us off. Can we move now to Alison?
Great, thank you, Ruth and Kate. That was really fascinating. Really enjoyed it. And I suppose I had two things. I wondered, looking at the public's perception, why we're still using the word virtual. It seems that I'm not sure that anybody sees that as a benefit. It's very difficult. These things go in whims and they can't just disappear overnight, can they, really? But I just wondered, it doesn't seem a useful term, does it? So I wonder whether we might go away from that. And that's just a comment. And the other thing was about the health professional stuff, which I can see how much work there is all behind it. It looked really, really interesting. I wondered whether there was any tension between different roles, perhaps more within the actual service rather than referral into, in sort of workload and things like that. Perhaps that's a bit too in depth, but I just wondered whether there was that, the work gets transferred to other people, that type of scenario.
That didn't come out actually, but the only tension that came out in our report was particularly around paid carers, and they didn't view virtual wards very positively because they said, well, we've got our visits and everyone's coming in and disrupting what we're doing. That was the only tension that we picked up. We didn't hear anything around sort of workload or anything like that.
But I think we were probably, I think we were probably quite surprised by the amount of clinicians and staff that were talking about the sort of job satisfaction, the better job satisfaction, increased job satisfaction they got from working in that way than they did from in sort of acute settings, which came as a surprise to us, I think. So that's something to hold on to.
Thank you.
Great, thank you, Alison. And Anne.
My microphone is playing up a bit today, so can you hear me okay, Ruth?
Yes. Yeah, we can. Yeah.
Perfect, excellent. Well, shout if I go a bit funny.
Yeah, we'll do.
So an observation and a couple of questions, if I may. I think it was a brilliant report and loads of great insights. And I see today it's announced that DOCLA are doing some extensive work. I think it's in Derbyshire, where that's been announced a new way of delivering healthcare. So a couple of questions. Some years ago, I went to Wales to deliver an award to a dialysis at home service that was being provided. And the patients loved it. All the kind of usual sort of trepidation beforehand, same sort of findings as you've discovered today. But once they were provided with the equipment and the training, they loved it. Is that the type of thing that you would now sort of consider as part of virtual ward delivery, because it's a long-term, condition being provided that care? And my second question is around sort of training need for those staff delivering. Are there sort of particular skills and competencies that have been identified that for those staff delivering the at-home service that need to be sort of addressed, and how's that being done? Thank you.
Shall I come in?
On that?
Oh, you go.
I was going to say, Charlotte, could you do the first bit and Bex do the second bit?
Yeah, sure.
Perfect.
Thank
Yeah,
you.
on that first one, Anne, I think we just need to be careful with the distinction between long-term condition management at home and virtual ward / hospital at home, which we're talking about today. This is for people with acute care needs who would otherwise need to be admitted into hospital. So I think there's definite benefits to providing dialysis at home, like you were saying, but that's more about long-term condition management as opposed to acute care needs. So slightly different, although there is obviously overlap. Bex, I'll hand over to you.
Thanks, Charlotte. Yeah, I was going to say the same thing in terms of that, but I think the key there is how that is then joined up. So if they become acutely unwell and they're having their dialysis at home, what can we do to wrap around and provide that integrated care to keep them at home rather than them having to bounce into hospital? Now, that won't always be appropriate, but there may be times when it is. So it's how we can create that seamless pathway of care for that individual, that personalized approach. And then thinking about the staff skill mix, well, of course, there are thousands of people who work in the community anyway, who have a huge amount of skill that we tap into. Many of our staff from BNSSG are also staff who have previously worked on an acute, medical surgical ward within the hospital, but we do a lot of skill sharing. We do a lot of additional learning across our teams. There are some nuances as well for the purely remote bits around considering how you're talking to patients and their carers over the telephone and the nuances of what you might glean from that conversation. In addition, this is particularly when, let's say, for example, a clinician, healthcare professional is looking at a dashboard and can see that one of the observations or the News 2 score has elevated, and you're then phoning the patient to find out how they are and perhaps get them to repeat it. So there are some skills to think about around that in terms of the way that we communicate, in terms of, then the nuances of what you can learn just by hearing someone's voice. But I think the other skills are, that they're eminently learnable. And I think what we find for we do have a real mix of healthcare professionals within our teams, and we try not to talk about banding. We try to talk about a particular skill and availability of skill rather than a band 5 nurse or a physio because actually there's much more blending across the workforce. And I think that makes it more interesting and exciting. In fact, they are more generalist roles than they used to be, and staff are more able to learn more skills. That can come with anxiety and nervousness as well. If you've been a surgical nurse for many years, used to working on a surgical ward, and you move into this pathway, but also it's an opportunity to do something new. So I think there's a balance there in terms of, learning, training, knowledge, but I think it can make it quite an exciting and interesting place to work as well. And also gives opportunity for people who can't continue with face-to-face clinical care, who want to. So we have someone who actually works remotely and doesn't even live in BNSSG, looking at the dashboard, is unable to do ongoing face-to-face care for particular reasons. This allows them to keep up that clinical skill and knowledge. So yeah, different ways of working.
Great, thank you. And Rebecca.
Hi. Hi, I'm Becky Housley, and I'm the consultant nurse working at Hampshire Hospitals that supports all the virtual wards. So just to say a massive thank you for all your support with this work, and it's been fantastic working alongside you trying to support this. I think one thing that's just been highlighted to me for the report, there's been loads of positives that have been brought from this piece of work, which is really valuable for us. But I guess the big piece that sort of sticks out for me is the public perception of virtual wards and how we're going to manage that, because that's bigger than us within the Hampshire hospitals, and how we support the public in understanding what virtual wards are. And I'm not quite sure how we tackle that. And that's probably, that may be part of the ICB, the government. There needs to be a lot more drive and understanding for the public. And we can only touch the edge when people come into hospitals to try and support them. But the bigger piece of work is huge. So it's really highlighted that to me about how we're going to tackle that going forward. But thank you so much. It's been fantastic and fantastic presentation.
Great, thank you, and thank you for all your support in it as well, because it's obviously taken time, didn't it, to get all the people together. So thank you for all your team support as well. Charlotte, did you want to come in?
Yeah, I was going to say, Rebecca, that's a really useful point and valid point. And I think there's a lot that we need to be doing nationally as well around that, which also leads me into a reminder that I was given by our comms lead today, just to let you all know about our Virtual Wards Bulletin as well, which is about showcasing virtual ward success stories, really getting the message out there. I'll post the link into the chat as well, but I would really recommend that you sign up for all information virtual wards.
And I do think there's some, and I'm sure there's lots of thought being put around this, but some thought around some sort of toolkits around messaging and marketing of this sort of area of work, so that we're consistent as well. I think some of the problem for the public is that the language is used is so different in so many different areas that how can we expect our population to really understand what we mean?
I agree, Kate, and I think it's about honesty as well, honesty with our populations. I know certainly when we started out in this sphere, in particular when we started looking at supporting patients who'd had elective procedures, there was that real sense of, well, you're just shoving us out early because you haven't got hospital beds, not recognising the other benefits. And that narrative around this is a cultural shift for the way we deliver healthcare. This isn't just another bolt-on fancy idea that's going away. And so the language that we use is absolutely paramount, and the way that we deliver that comms to our population as a shift in culture around well-being and health, and not just a bolt-on service and another silo, is key.
And just to add to that, and I can see the time, but there was, and we haven't actually touched on this in the report, but there was a sense that comes out in the full report of some sort of cynicism amongst the public around virtual wards. So what's the political motivations around them? That again pushing you out, and the comms needs to really work hard to address that.
It does. Thanks, Kate.
Great, thank you very much. Just on the last minute, any final questions? Thank you for those that have posed questions. They've been really interesting questions, so thank you. If not, I just want to say thank you very much to Kate, Bex and Charlotte for joining us on our session this lunchtime. It's been a really helpful and informative session, and be able to showcase our report to you. I've put myself and Kate's contact details in the chat, so if anyone wants to talk to us further around virtual wards, or indeed our report, and wants to see our full report, then please get in touch. But just want to say a big thank you to I think we've had about 50 odd people on the session this lunchtime, which is fantastic. So thank you to everyone for joining, and hope to speak to some of you soon. Thank you very much.
Thanks so much.